Hey everyone, I know class time is super valuable, so we're going to take a moment to go through the GI midterm review exam, and we're going to go question by question. There are 30 of them, and go through the correct answers and how well y'all did. So let's go ahead and dive in. All right, so first question, we have a 16-year-old female who presents with a 2-year history of ulcerative colitis. And they have signs of acute exacerbation, abdominal pain from frequent passing of large quantities of blood and mucus. So sounds kind of out of control here. She's been treated with sulfasalazine, glucocorticoids, IV alimentation. Diarrhea decreased markedly, but her status continues to deteriorate. She has some tachycardia, fluid depletion, and a fever. On physical exam, we have abdominal tenderness, but no mass is observed. And plain radiography shows a transverse colon is dilated up to 7 centimeters. Ooh, what's the most appropriate next step? So, what do y'all think? What do y'all think? What does this sound like to you? She has a big colon, right? A big colon and a history of ulcerative colitis. So, to me, it looks like a toxic megacolon, right? So, we're going to need to take out the section that is enlarged. So, again, characteristics of toxic megacolon, we're going to need a colectomy. We need to open her up, do surgery, remove the dilated abnormal bowel. All right. Next up, we have a 66-year-old male, history of obesity, hyperlipidemia, 8-month history of burning in the chest. So usually when I see burning in the chest, I'm thinking probably GERD, but let's keep looking. Sensation, midline of the chest provoked with bending over. So it is positional. You remember he is a little bit overweight. And it also has to do with tight clothing after eating a large meal and when he lays down. So again, kind of proving my GERD thing. Um, he denies chest pressure, shortness of breath, so it doesn't sound like a cardiac or pulm type of issue. Physical exam unremarkable, upper endoscopy, inflammation in the esophagus. So once we see inflammation in the esophagus, we know we probably need to add on a PPI. So most important pharmacologic intervention, I'd say PPI. Which one of these is the PPI? If we look through, we see omeprazole. So y'all did really well, and 98% of us got that one right. All right, 58-year-old woman, 3-month history of postprandial abdominal pain. It always occurs 30 minutes after eating. Due to these symptoms, they've lost about 30 pounds and they're afraid to eat. So there's food phobia. Okay. Past medical history, she has hypertension, she has CAD, okay, and she's had stents before and had a carotid endarterectomy. So it's making me think, atherosclerosis, problems with maybe thrombosis, and she is also a smoker. So that, along with postprandial pain, sounds to me like it's probably some sort of occlusion, vessel occlusion in the gut. Okay. And so I'm thinking I probably need a CTA to help me determine whether or not there's blockage in the vessels, the mesenteric vessels of the gut. So great. So we don't usually do ultrasounds to tell us about blockage of vessels within the gut. And then the mesenteric angiogram or arteriogram, we would save that. It's a procedure. So we wouldn't do that as first line for this initial test for this. Okay. And barium enema, well, that's not even a good option. All right, winter. It's telling you this for a reason, okay? So pay attention. Usually we're talking about viral stuff when it's the winter, right? But we never know. 11-month-old female, 2-day history of vomiting and diarrhea and fever, routine medical care since birth, no significant past medical history. We have a fever, some dehydration, white blood cell count doesn't seem to be too elevated, and his stool negative for blood or white blood cells. So what do we think? It's the winter months. It's a young baby, probably rotavirus, if I had to guess. Good, y'all said that. So norovirus, we usually don't describe it in this way in a vignette. Usually we describe it as more close quarters, although it can pass around in a daycare or in a setting like that. This one I would call rotavirus in a kiddo in the winter months with a non-bloody diarrhea. I'd say it's rotavirus. 36-year-old woman with 24-hour history of sudden severe diarrhea. Profuse gray color watery stool without fecal odor or blood. She's had some recent travel, and the diarrhea began after she returned. She has a little bit of an elevated temperature, dry mouth. So, what do you think this is? The way that they describe this gray, cloudy, watery stool? To me, that sounds like rice water, right? They didn't say rice water, but it kind of sounds like it. So, I'm thinking it's probably Vibrio. That she's also very dehydrated, which is usually what happens when we have this type of a gastroenteritis. So, I would say Vibrio. Good. So ETEC, a lot of folks put that one thinking it's travel related, but with this, we don't usually see so much diarrhea, and the way that it's described, that's usually not the way they describe an ETEC, just normal colored diarrhea, not gray watery stool. So that would be the way I would differentiate that. Okay, 52-year-old man, 3-day history, persistent diarrhea. 7 watery, non-bloody bowel movements associated with lower abdominal cramping. Denies recent travel. Doesn't recall eating anything. Family members are not sick. Let's see. Past medical history has GERD. He takes pantoprazole daily, which sometimes can cause some diarrhea. Um, and recently completed a course of oral levofloxacin for pneumonia. Okay, so he had some recent antibiotic use. Stool sample, negative for ovarian parasites, but we do have C. diff, so that makes sense, right? Appropriate first-line treatment for C. diff. C. diff. So I would say in this case, vancomycin, but I'd be even more comfortable if it said oral vancomycin or fidaxomicin. So good, y'all did pretty well. Clinda does not treat C. diff, but it does cause it. 75-year-old woman, heartburn, dyspepsia, diagnosed with osteoarthritis 4 years ago. So generally speaking, when patients have osteoarthritis, they tend to take a lot of NSAIDs, so that's probably why they're putting this in here. 18 months, been taking naproxen. See, there you go. And gastroenterologist said the patient needs to be tested for H. pylori. What's the most sensitive and specific non-invasive method to diagnose this infection? So that was all just for nothing. The naproxen really didn't help us out there. We're just basically being asked what's the best test for H. pylori. And if I had to choose between all of these, I'd choose urea breath test. Good. So fecal antigen, not quite as sensitive and specific. And we don't usually do cultures. We can take biopsies that look for it under the microscope, but that's more invasive. Okay, that would be more invasive. That's asking for non-invasive. Okay. All right, let's look at this one. So we have a 63-year-old woman who presents with a 6-month history of difficulty swallowing, saying that shortly after she swallows, she feels like something's getting stuck in her upper chest, and she has difficulty swallowing. It seems to be worsened with stress and with eating hot or cold food. No weight loss, physical exam normal, and she's had an EGD which was negative. So, what's our first line treatment for this patient's symptoms? I think this is a little bit vague. I think it's kind of hard to tell exactly what this patient has, but the fact that they mentioned that it's related to stress and that the EGD is normal, I can rule out some of the obstructive causes of dysphagia as well as some of the ones that I would expect to see changes for on an endoscopy. So, like achalasia, I would expect to see the tightening of the musculature at the distal esophagus. So, what I'm seeing here is it's precipitated by eating hot, cold foods and stress, which makes me think that it's probably DES. And so, when we have a patient with DES, we usually we usually start with endoscopy anyway. We're looking to rule out other things, but we probably would do a barium swallow. And the first line treatment for this is actually PPIs, but I do not see PPIs listed here. I don't see any PPIs. So then we would move on to something more like an oral diltiazem. So that would be my first treatment here. So it looks like we had some varying things here. So injected Botox we would do if we saw some sort of stricture or tightening. We would probably see that on endoscopy, but we didn't see anything like that. We didn't see any evidence of achalasia or anything, so that wouldn't be the first thing we would do. IV nitro, we don't usually use IV meds for something like this. This is 6 months going on. It's chronic. This IV is something we would do in an acute setting, right? Prednisone. Nowhere in here does it mention anything about something that would react well to steroids, like eosinophilic or anything like that. So I would stay away from steroids in that case. And then metoclopramide is Reglan. We use that for like a gastroparesis, which this doesn't really look like gastroparesis because gastroparesis is in the stomach. And it sounds to me like the problem here is in the esophagus. So the best answer is going to be that oral diltiazem, which is a calcium channel blocker. Okay. All right, let's look through this question. So we have a 44-year-old man who comes in with reports of heartburn, substernal pain, regurg, and difficulty swallowing. He likes to eat a lot of really fatty, greasy foods, so hamburger steaks, um, extra butter, heartburn for years. Relieve the heartburn, he takes antacids, but this time pain is worse, so he's eaten a large fatty meal and denies any other medical problems. He is overweight. And what's asking is what the most likely diagnosis. Well, they said heartburn several times. They haven't said anything about a gnawing pain. They haven't said anything about bleeding or anything like that, or H. pylori. So I don't think it's peptic ulcer disease. They also haven't mentioned any other risk factors for squamous cell neoplasms. Maybe adenocarcinoma from the long-term GERD, but I don't think squamous cell. Varices, they haven't mentioned anything about bleeding or liver disease. And biliary colic, usually more right upper quadrant pain following fatty meals, and it's more common in females than in males, although males can get it. So I'm thinking this is probably just a case of GERD, which is what y'all thought and which is what is correct. 50-year-old, family history of colon cancer, had a total colonoscopy, screening guidelines for colon cancer. They found 2 polyps, which are 5 millimeters each, and the doctor advised the patient to have her colonoscopy repeated in 3 years. Okay, so when we have, depending on the pathology of the polyps that we remove, that's how long we wait to do surveillance colonoscopies. So in this case, she was recommended to come back in 3 years based on the polyp that she had. So hyperplastic polyps don't increase your risk at all. So a lot of times they won't change the guidelines for returning with the hyperplastic polyps, and same with hamartomas. Um, then let's look at these. Inflammatory, we didn't even talk about inflammatory, but we can basically narrow it down to tubular adenoma versus villus. So I'm going to tell you this. I didn't quite talk about it in this detail in class, but a tubular adenoma is the better of the two between villus and tubular. They're both adenomatous, but tubular adenoma, we actually can take the surveillance out to 5 years because this is the least malignant potential. But the villus adenoma is the one we want to do within 3 years. So that one should have been the correct answer. And that was hard because I didn't really talk about it that much, but hopefully answering this question kind of helped you. All right. 49-year-old woman, dysphagia, difficulty swallowing, regurg of undigested food, bird's beak appearance. Okay, this one's easy. I would expect y'all got 100% on this one, it being achalasia, because it said bird's beak. Ooh, boom. Y'all did really well. Great job. All right, 53-year-old man presents with increased difficulty swallowing, regurg of meals, symptoms been more frequent over the past 4 months, chronic heartburn, treats with over-the-counter antacids, no regular medications, no surgeries, smoker, no alcohol, no recreational drugs, a little bit overweight, labs, EKG, X-ray, all normal, biopsy, intestinal metaplastic cells. Okay, so we're thinking probably some sort of Barrett's esophagus here, the metaplastic cells within the distal esophagus. So when someone has Barrett's esophagus, we need to treat them with PPIs. Okay, we don't do antacids anymore. We don't do H2 blockers. We do PPI. So which one of these is the PPI? Esomeprazole. Let's go with that one. Perfect. So famotidine, again, that's a H2 blocker. We don't do those for Barrett's esophagus. For Barrett's, we always use PPI. All right, let's go ahead and look at this question. So we have a 15-year-old girl presents with 1 year history of intermittent abdominal pain, nausea, and occasional bloody diarrhea. Okay, so she's had it for a year. Sounds more of a chronic issue. And she's a teenager, so potentially thinking some sort of IBD. But let's keep reading. She denies any fever or weight loss and no travel history, although I don't think she'd have some sort of GI bug for a year. Past medical history has migraines, takes a multivitamin, vital signs are okay, diffuse abdominal tenderness, guaiac positive stool, otherwise normal, and she's a little bit anemic, and her white cell count's a little elevated. So, what's the most appropriate next step in her management? So let's look through these. So stool studies and a colonoscopy, I think that's pretty good. Let's look at some of the other ones. Beginning trial of antibiotics. So do you think that a bacterial gastroenteritis could be affecting her for a year or more? I doubt it. So I wouldn't put that high on my list. Have we talked about an ultrasound being a good test to look for IBD? No. Monitor clinically, schedule follow-up an appointment too. Well, we kind of want to know what it is that's causing it. Bloody diarrhea is not normal. It's a red flag. So I think this would be something that we would do maybe for an IBS, but definitely not for a suspected IBD. And then, do they require immediate referral to the emergency department? Well, it's been going on for a year. Their vital signs are normal. So I think this is something that can be continued to be worked up on an outpatient basis. So I don't think we need to immediately send them to the ER. So having gone through all these, I'd say A is our best choice, which y'all agreed with. Good. All right, let's take a look at this one. So we have a 25-year-old who's coming in for intermittent chest pain. The burning sensation in his chest says 1 to 2 days per week is after eating. Worse with large meals, late eating late at night, alcohol, uh, no difficulty swallowing, weight loss, night sweats, chest pain, so no red flags here, and vital signs are normal. So it sounds to me like he has GERD, and it's pretty intermittent. It's not very consistent. It's just one, maybe 2 times per week, but not too bad. So it sounds like something that, and he's young, healthy, no red flags. This sounds like the patient I could probably start on an H2 receptor antagonist and then work their way up to PPI. So let's see what we put here. Good. So we were torn between the two. So when we have patients intermittent, young, healthy, no red flags, less than 2 times per week, we can start with the H2 blocker. And this is a question from a normal Q bank. So that's probably why they started the H2 blocker. And again, I'll post these so you can read the explanation, but basically saying it's less than 2 times per week. It's mild, it's intermittent. So we can start with the low dose H2. All right. 15-year-old boy, abdominal pain, rectal bleeding. Family history significant for premature deaths of his mother and maternal grandmother from metastatic colon cancer. Ooh, it sounds like some sort of familial polyposis syndrome or something. Sorry. Okay. Both died before the age of 35. Autopsy, hundreds of colon polyps. Okay. Along with cancer. So that sounds like blankets of colon polyps. Endoscopy, endoscopy. Remember, when we say endoscopy, it can be upper or lower, but they're talking about lower endoscopy here. Demonstrates extensive colonic polyp disease. So it sounds like FAP, familial adenomatous polyposis. So we're asking about the gene mutation. So which of these genes is for FAP? It's APC. Good. All right, 54-year-old long-term GERD, been on PPIs, had fair control of his symptoms, non-smoker, drinks socially, had some hypercholesterolemia, exam unremarkable, endoscopy a few years ago showed Barrett's, okay? And he was recommended to have follow-up every 2 to 3 years with biopsy. So, what potential condition is the reason why this screening was recommended to him in the first place? So, it sounds like he has Barrett's, he has a long term GERD. So, we're looking to prevent or to find before we can adenocarcinoma of the esophagus. Good, great job. So, remember, squamous cell is not usually caused by GERD. It's usually more, we see it more often in patients that smoke and drink. But this one, because he has remarkable for GERD, let's go for the adenocarcinoma. All right, this is a pretty long one, so let's break it down. We got 14 years old, 2 week history, 4 to 5 bowel movements with blood and mucus, so definitely not normal. With tenesmus, cramping, abdominal pain, low grade fever. Sounds to me like an IBD. Episode's been happening for 6 months, so it is more chronic. Vital signs a little bit hypotensive, no fever, normal pulse. Normal oral and perianal examination, so probably leaning more towards an ulcerative colitis, but keep going. Abdominal tenderness is present. Let's see, stool examinations are negative. Labs are going to show us elevated ESR and CRP, non-specific, and anemia. We had a positive PANCA and a negative ASCA. Colonoscopy. So we have hyperemic edematous, friable, and ulcerated rectal and colonic mucosa, but no normal mucosa in between. So that again kind of points us more towards ulcerative colitis than the Crohn's. And the upper endoscopy shows normal, so nothing up above, everything within the rectal and colon with no skip lesions. So we need to understand by reading this that it is ulcerative colitis, and then from there it's asking us what's the most likely complication that can occur in the patient at this stage. So young, 14 years old, relatively newer patient. Um, so ulcerative colitis doesn't typically cause intestinal obstruction, not nearly as often as Crohn's does, but it can happen. Perianal fistula, this is not a transmural disease, so it doesn't cause fistulization. It can cause toxic megacolon, however. Now, he's not had it quite long enough to have a higher risk for colon cancer, but he does have a longer term higher risk of colon cancer, usually 8 to 10 years after he's starting with the symptoms. So I don't think he's there yet. And then HUS, we don't typically get in patients. Well, we don't get it in patients that have ulcerative colitis. We usually think of it with the E. coli, 017H7. So toxic mycocolon was the correct answer here. 63-year-old, acute onset of abdominal pain, steady deep discomfort, left lower quadrant. Remember, abdominal pain, left lower quadrant, first thing I'm thinking of is diverticulitis. She was constipated, so she's having alternating bowel movements. She has a temperature and left lower quadrant pain with guarding and rebound tenderness, positive fecal occult blood. What's the best test to determine the most likely diagnosis? So we're thinking diverticulitis. Best test is going to be a CT. So let's see, what do we see here? Do we want to do a colonoscopy in this case? No, we want to stay away from it in diverticulitis. So let's see what we put. Oh, some of us did the wrong thing. Remember, it's contraindicated in acute diverticulitis. Abdominal CT is the first line. It would usually be abdominal pelvic CT. It would include both. 58-year-old, recent episode of rectal bleeding. Brief history reveals bowel patterns have been increasingly erratic. 2 to 6 days without bowel movements, followed by copious production of coils of stool. Lost 10 pounds. Family history of death of a cousin from colon, so he has family history of colon cancer. He's pale and febrile. Rectal exam, he positive with scant stool and his prostate softly enlarged. So what's the most appropriate evaluation method for diagnosis of colorectal cancer? Well, in this case, I think we need to do the colonoscopy. Yep. Okay. 100% of us got that one right. So, someone with a history with a higher risk of colon cancer that's having abnormal bowels, we need to do a colonoscopy. 3-year-old, 1 day history, irritability, and weakness in her legs. Neuro exam reveals an ascending paralysis. Sounds like maybe a Guillain-Barré. And then lumbar puncture is going to show us kind of some abnormalities there. Medical history had a recent recovered diarrheal illness. So which diarrheal illness is related to Guillain-Barré? We look through here. It's going to be Campylobacter. Very good. Don't get your C's mixed up. All right, 60-year-old African-American man presents due to dysphagia. Dysphagia started 3 to 4 months ago, progressively worsening. He's losing weight. And he appears older than his stated age. And let's see, he does not have heartburn. He doesn't eat on a regular basis. He eats fast food, smoked. He also drinks. So he has risk factors for squamous cell carcinoma, it looks to me, African American, uh, smoking and alcohol. So let's look, and he's got weight loss. So he has some scary red flags for possible esophageal cancer. So it's not actually asking us to differentiate. It's just saying esophageal neoplasm, but I would pick that. Good. Did good. All right. Early one afternoon, 12-year-old boy, parents with ER, right lower quadrant pain, anorexia, nausea, and vomiting, and rates his pain at 8 out of 10. Pain started around umbilical area and has moved to the right lower quadrant. Okay. So let's see. Well, this sounds like acute appendicitis to me. Based on suspected diagnosis, what do you expect to find on physical exam? So colon sign. Colon sign is not found in this. It's a acute pancreatitis around the umbilicus, so it's ecchymosis. Murphy's sign is for gallbladder. That's right upper quadrant. Great turners is going to be ecchymosis on the flanks from pancreatitis. So Rovsing sign is the only one that is associated with acute appendicitis. So Rovsing. Good. 33-year-old man, sudden onset severe chest pain. Mildly febrile, says he's had 4 to 5 episodes of forceful vomiting, after which he had the severe chest pain. Ooh, that doesn't sound good. Okay. He appears ill, diaphoretic. He has a low pressure and a high tachycardia. Okay, lung sounds decrease, the left lung base, and abdominal exam, tenderness in the gastric region, no guarding. EKG shows sinus tachy with no ST segment changes. So it sounds to me like he was retching, and then he had this acute boom where things got worse. So it sounds to me like maybe a Boerhaave syndrome. Boom, good job. You're performing annual physical exam on a 14-year-old girl. Started by having constipation about every other day or so, followed by loose stools. And she still feels she's depressed because of her parents' recent divorce, has no problems at school. Mother's worried because she's very slim, even though she has a good appetite. Still hasn't gotten her period. A lot of times that happens when patients are malnourished. Let's see. She's got a lower BMI. She's bone age 12.5 years. So it looks to me, when I look through all of this, she has a positive TTG antibody. So it sounds to me like celiac disease when I look through this. So we have a malnourished young female with a positive TTG. So I'd say that we need to have a gluten-free diet. Good job. Early one afternoon, 15-year-old boy, abdominal pain, nausea, vomiting. Pain's been worse since the onset. No GI disease. Physical exam, no abdominal tenderness, but a positive psoas sign, and tenderness on rectal exam. Temperature and pulse are slightly elevated. Skin turgor reduced. There's a 10 millimeter drop in postural blood pressure. So he is orthostatic. And he also has a high white cell count. So it sounds to me like he has appendicitis. He got right lower quadrant pain. Or he doesn't necessarily have right lower quadrant pain, but he has abdominal tenderness or pain that he's presenting with. It's not tender. It sounds to me like he has like a retrocecal appendix because he has a positive psoas sign and a high white cell count, and he's a young person. So I'd say acute appendicitis, probably retrocecal. Yeah, retrocecal. All right, 28-year-old woman, bloody diarrhea for a week. Similar attacks in the past subsided on their own, so maybe a chronic thing, maybe IBD, I'm not sure. Negative for ovum parasites, culture didn't grow anything. Sigmoidoscopies performed, a friable erythematous mucosa extending from the rectum to the mid-descending colon with broad-based ulcers, and biopsies taken from the rectum, mononuclear inflammatory infiltrates, blah, blah, blah. No granuloma seen. So it sounds to me more like UC than Crohn's based on her bloody diarrhea and the fact that it's only in the rectum and the colon. So good. 46-year-old woman, nausea, vomiting, cramping, abdominal pain, loud bowel sounds past several hours. One normal bowel movement since then, but did not have any improvement in her symptoms. She's had her history of surgery. So I'm thinking maybe SBO. Physical exam, hyperactive, high-pitched sounds. Yeah, it's got to be SBO. Great job. 20-year-old college student, 7 days of daily heartburn. Never experienced heartburn as bad as she does currently. Treating with over-the-counter H2 blockers, and she has no significant other past medical history. She has increased episodes of headaches she believes are due to stress. She's been taking ibuprofen, 600 milligrams every 8 hours. She's been taking this consistently for 10 days. And she's also given amoxicillin 2 weeks ago for a middle ear infection with resolve without any further intervention. All right. So physical exam unremarkable. What medication is likely causing her increased GI symptoms? So this is kind of a tough question because we have two medications that look like they're new. We have the ibuprofen and we have the amoxicillin. However, her symptoms sound more like a gastritis or an ulcer, right? Rather than C. diff colitis, which would be more diarrhea based. And so the amoxicillin might have caused C. diff, but it doesn't sound like C. diff to me. It doesn't have any black tarry stool, no change in the stools really. It's all kind of upper GI symptoms. So I would say she's also been on famotidine, I think is what they said, but that should have improved things, not made it worse. So I would say that the culprit here is going to be our NSAID. Good job. 100% of y'all got that right. That was good. 35-year-old routine physical exam, family history positive for FAP. We talked about this once before on another question. What screening test would be best for him to obtain? So, FAP, we need to have colonoscopies done earlier because they're eventually going to have a total colectomy. They have 100% of getting colon cancer. So, in this case, I think the answer's got to be colonoscopy here. Uh, a blood test's not going to help us. A fit's not going to help us. Stool DNA, they're at high risk, very very high risk for colon cancer. So we need to do the actual colonoscopy. AFP is not done for colon cancer. It is done for hepatocellular carcinoma as a screening tool, along with ultrasound. But maybe you might have picked this thinking APC gene, but that's not the same thing. And colonoscopy is still a better test. Yeah. Last one. 45-year-old man presents with 30-minute history of substernal chest pain, describes it as burning, denies any trauma, similar episodes many times. Voice is hoarse. He has diabetes and he drinks quite a bit. So, what's the most likely cause? Sounds like GERD to me. Sounds like GERD. Good. 100% of y'all got that one right. So, let's look at the results table again. We had some pretty good scores. Some pretty good scores throughout here. I think there was the lowest score is a 67, I think that I saw. 67, but most, and oh, sorry, 63. And so, I mean, those are not the best scores. I'm glad that you decided to take it without looking at your notes. I'd rather you get them wrong now than get them wrong on your test, and get 100 on this test doesn't mean anything. So my advice to you, if you did well on this, just keep going, stay up to date with the material we're covering in class, and start supplementing in more questions. You'll start to see the same kind of questions popping up over and over again, the same things they like to ask, and it'll just get you more familiar with what is commonly asked in the testing world. So thank you for sticking with me. I know it's kind of hard to go through these questions one by one. This will definitely save us some class time to do more cases and other things in class. So thanks for tuning in, and I'll catch you next time.